I'm Dr. Bill Nordquist. Thank you for taking the time out of your day to watch our video. As you can see from the material in the video, we spent a lot of time putting this together. I hope that you enjoy it.
The Custom Endosteal Implant is a new name that we decided to use for an implant modality that's been around for a long time, namely the subperiosteal implant. Over the years, many of us that work with the subperiosteal implant realize that this implant osseous integrates like any other implant modality. Until recently, we really had no proof of this, but in a soon-to-be published article by Drs. Martin and Lemons, they clearly showed that the subperiosteal implant osseous integrates. Therefore, the subperiosteal, which means under the periosteum, really no longer applies to this implant. This implant is actually placed and then augmented with synthetic bone along with PRP that promotes bone growth in and around this implant, so that actually it becomes fully embedded into the bone and becomes an endosteal implant rather than a subperiosteal implant. Therefore, we look for a term that would more accurately describe this, and the custom endosteal implant seemed appropriate. The subperiosteal implant indicates that you're placing the implant on bone and then putting the periosteum over it, and so it truly is a subperiosteal, where the way the custom endosteal implant is done with the augmentation and the way the tissue is treated and eventual integration, a custom endosteal, since the implant is actually in bone, became more appropriate. The custom endosteal implant is an osseous integrated custom cast titanium or vitalium implant that is either inlaid into the original cortical bone or embedded into newly augmented bone over the cortical or alveolar bone. In other words, this implant becomes part of the bone and becomes embedded and engulfed in bone. Fibrointegration subperiosteal implant, on the other hand, a fibrointegrated subperiosteal implant is an implant that is encased in a fibrous capsule. Fibrointegrated implants can sink into the underlying bone, causing nerve impingement in the mandible or sinus problems in the maxilla. A fibrointegrated subperiosteal, as well as a root form implant, is a failed implant. In other words, I think that over the years we understood a subperiosteal implant to be embedded in a fibrous capsule, and this was supposedly something that simulated the periodontal ligament and was a good thing. Dr. Bob James showed a lot of research in this many years ago, showing the sling that this implant was in, a fibrous encapsulation, and fibers that attached this encapsulation to the bone, and this was thought to be a benefit to this modality. But if a root form implant becomes fibrous encapsulated, we know that's a failed implant and it is removed. Some of the problems with the subperiosteal implant over the years is that it seems to sink into the bone, and we find this implant impinging on the mandibular nerve, and also we find them in the maxillary sinus. And a lot of big lawsuits 20-25 years ago resulted from implants settling into the sinus. And no one understood at that time why. But today we understand that if it's not integrated, the fibrous encapsulation allows the implant to move through the bone orthodontically, and that can cause problems with this implant modality. Promoting osseous integration of the custom endosteal implant. The custom endosteal implant distributes the load over the existing cortical plate. This transfers the load to the bone over a longer and a wider distribution area than, say, a root form. The strongest part of the bone is the cortical plate, and that's where the custom endosteal implant transfers the load. HA-coated vitalium or titanium. HA results in faster integration of the implant, similar to root forms. Also, we found that grip blasted and etched titanium osseous integrates as well. And these implants take a little longer to integrate, and they require a little more time for the osseous integration process to take place. The grip blasted and etched titanium needs to be progressively loaded, whereas HA-coated vitalium or titanium can be loaded much faster. The maxillary implant, the AP torque of the final prosthesis needs to be managed in such a way that the implant is not overloaded. And the restorative procedures we're going to show later is how we use an overdenture with a resilient liner that minimizes the amount of AP torque in the implant. Classification of the custom endosteal implant. The maxillary has three classifications: a class 1 where we have adequate height of the palato-alveolar ridge. We know from Linkow, he said that the support for the maxillary subperiosteal implant comes from the palato-alveolar ridge and from the anterior nasal spine. The ideal situation is a class 1 where we have very adequate height, where there's plenty of palato-alveolar ridge and of course the nasal spine. The more compromised but not a flat ridge class 2 is less height and less support, and the design of that subperiosteal implant needs to be distributed over more of the palate. The class 3 flat alveolar ridge, or the end of the line maxilla, these patients are actually dental cripples and dentures don't stay in. Our patients are very miserable with these types of dentures, and there's nothing for these patients to do but either have an extensive bone graft or what we call pulling out all the stops, maxillary custom endosteal implant. The mandibular custom endosteal implant seems to work no matter what you do. You can use an uncoated Vitalium or acid-etched Vitalium, acid-etched titanium, HA-coated titanium, but because of the density of the mandibular bone, any configuration seems to work. And on these implants, we're experiencing close to 100% success rate over the long period of time. The unilateral is classified into the maxillary or the mandibular, and these implants have been used in my practice quite extensively for the last 19 years. We use them mainly in the posterior maxillary custom endosteal implant rather than doing a sinus elevation, and we feel that that's important because it distributes the load over the cortical bone and is a much more solid implant. And then the unilateral mandibular, again, as long as we have struts going over the external oblique ridge, these unilateral mandibular custom endosteal implants work very, very, very well long term. Maxillary custom endosteal implant is a valuable and it's an indispensable tool for the restoration of the edentulous maxilla. In situations where root forms will not work or ridge splitting and augmentation are not appropriate, the custom endosteal implant becomes the implant of choice. The accuracy of the new CAT scan technique has made it possible for a single surgery procedure. Even though most of the cases I do are direct bone impressions, there are situations that a CAT scan makes it easier for the patient that's very apprehensive about the procedure, or one who we feel will not tolerate two surgeries quite as well. We'll go ahead and do a CAT scan technique on that patient and reduce the technique to a single surgery. Rationale for the maxillary custom endosteal implant: combination syndrome, alternate to hip graft procedure with subsequent placement of root form implants. For most patients with severe maxillary atrophy, the custom endosteal implant is the only alternative. We find that over the years that combination syndrome is so prevalent in my practice, and dentists are very easy to place an upper denture against lower 6 teeth and a partial. And we know that over the years that the difference of load between the upper and lower and the strength of the lower natural teeth against an upper denture will eventually resorb all of the bone in the maxilla, at least the anterior. So we find that treatment of combination syndrome with the maxillary endosteal implant is very valuable. The class 1 ridge is a ridge that is high and has plenty of palatal bone, as shown here, and then has a very defined nasal spine, shown here. The ascending palato-alveolar ridge is probably the most supportive part of the maxillary endosteal implant. When you look at the ridge is almost a knife edge, and there's no possibility of cutting this ridge down